Today we'll deal with poliomyelitis. The poliomyelitis is caused by these three viruses, Lyon, Lansing and Brunhilde. You can have an antibody vaccine against them, which is called as SARC, or attenuated virus vaccine, which is called as Sabin. The Sabin vaccine is an oral polio vaccine given at monthly intervals 3 times in the baby. This attenuated polio virus needs a cold chain to get to the baby, and hence it's more difficult to give. And it was given in a program which is called as the Pulse polio program, and this 3-4 pulses were given at national level so that all the children at a particular age became immunized. This vaccine given orally gets into the intestine and the virus starts growing in the cell, so that new virus cannot come. This is achieved by the interferon mechanism. It is achieved by the interferon mechanism. Then the virus enters the body and there is a systemic immunity against the virus also. And all 3 types of viruses are there in the Sabin vaccine, Lyon, Lansing and Brunhilde. Then this virus is secreted in the feces of the immunized and immunizes the rest of the population. That is called as herd immunity. And Pulse program was done to generate this herd immunity, and this led to wiping out of the polio from the Indian subcontinent. So this mechanism has to be clearly understood. Now the Lyon, Lansing and Brunhilde viruses are enteroviruses. That means they grow in the intestine. They are secreted by the feces and they affect the other person by the oral route. They come into the intestine, grow into the intestinal mucosa, and then they travel by bloodstream, by axons and by perineural lymphatics into the spinal cord, into the anti-horn cell. It may be in the medulla region, the anti-horn cell of the spinal cord, or the nuclei of the cranial nerves. Now, this cell is a stellate cell. It has got dendrites, these are dendrites, and it has got axons. So this is an axon. It has a large central nucleus. It has a granular cytoplasm. These granules are called as Nissel's granules. Now, surrounding the cell is the glial tissue, the connective tissue. And what happens in polio is that the cell becomes round, the nucleus becomes pycnotic and peripheral, and the cytoplasm becomes clear but cloudy. Clear but cloudy. And this cell will finally die. Then in the glial tissue you find this blue colored dots which suggest edema, inflammatory edema. And around the blood vessels you find lymphocytes cuffing it. So these are the histological changes in the spinal cord, and the edema being most important because it presses other cells. So as you find that if there is an infection here, for 2 days nothing happens, this is called as incubation period. Then when the virus is in the blood, then there is a pre-paralytic phase, when there is an influenza-like sickness, different from other influenza-like sicknesses because there is acute muscle tenderness. Because there is acute muscle tenderness. So then, after the pre-paralytic stage, there is which may last for 2 weeks. There is a stage of increasing paralysis for 2 months, then decreasing paralysis for 2 years, and then residual paralysis. So these are the clinical stages of polio: incubation, pre-paralytic phase, increasing paralysis, decreasing paralysis, and residual paralysis. So in the pre-paralytic stage, with fever only, you can diagnose polio by acute muscle tenderness. And if you send the stool, they can culture it on guinea pig or on chicken embryo or monkey kidney tissue culture and demonstrate the virus. Now, how do you manage the acute polio? In the influenza-like sickness, you have to recognize it and differentiate it from influenza. And then you have to splint. You have to give hot saline fomentation, which is called as Sister Canny's treatment, because Sister Canny was an Australian nurse who treated large number of polio cases by hot saline fomentation. So this is called as Sister Canny's treatment. No injection, no injury, and look for bulbar polio. If cranial nerves are involved, you must transfer the patient to a place where there is respiratory support or ventilator. Now you recognize the recovery phase by absence of acute muscle tenderness. You continue the treatment of splintage. Moving all joints through their complete range every day so that there is no contraction. The splint that you use is a long listed splint, with a foot piece. Now the long listed splint keeps the hip and the knee straight, and the foot piece keeps the foot in neutral position, prevents equinus. So this long listed splint is used to prevent contracture. Then muscle tone of paralyzed muscles maintained by, if there is no active movement, then galvanic stimulation initially, which is for greater than 3 millisecond current, and you can keep on doing the string duration curve. If there is a stimulation less than 3 millisecond possible, then it is through the nerve, and that is Faradic stimulation. So galvanic stimulation, then Faradic stimulation. Then active exercises, first assisted, then without assistance, and then resisted. So this is how you maintain the muscle tones of paralyzed muscles. In the residual paralysis, you have to correct the deformity and you have to substitute the weakness or stabilize it. So stabilization is done when the paralysis is extensive. That means in the hip, knee and ankle. Then you use an orthotic device or caliper. This is called as caliper. If the problem is localized, then you do a tendon transfer, a bone block, or a fusion. We'll give you examples of an orthotic device. So this is the upright, and here is the shoe, and there is a lock, a posterior check, which will prevent this foot from plantar flexing or dropping. So this is an orthotic device. Okay. then you know that if the foot is dropping, then the dorsiflexors of ankle are paralyzed, and the main one is the tibialis anterior. It can be substituted by extensor hallucis longus, extensor digitorum longus, extensor digitorum longus, tibialis posterior or peroneus longus. So if these muscles are powerful, you can do a tendon transfer. If not powerful, you can raise a dicky type of raise from the talus, and as soon as this foot starts dropping, this will block, this will strike against the posterior margin of tibia and will block the foot drop. So this is called as bone block. You are using a bone to block the not required movement. And if there is pain or there is instability of the ankle, then you have to fuse the joint. So that is fusion. So tendon transfer, bone block fusion for localized paralysis, and caliper or orthotic device for many joint involvement. Now, as far as before you can give a device or do a tendon transfer, there must be full passive range of movement and no contracture. So contractures initially deal with stretching, traction, physiotherapy, but if not, then you do release surgery, operation to correct contracture. So on the hip, you do what is called as a suture's operation, in which the tensor fascia lata, you make an incision from the anterior superior spine downwards. On the lateral side is tensor fascia lata, on the medial side the sartorius. You divide the tensor fascia lata, you divide the sartorius, you divide the deep fascia attachment to the inguinal ligament, and you also divide the straight head of rectus femoris, which is arising from the anterior iliac spine. So this is suture's operation, which will release the flexion, abduction, external rotation, flexion, abduction, external rotation contraction at the hip, like the tailor sits cross-legged. So that contraction is released by suture's operation. The knee flexion is released by Yount's operation, in which, if this is the bone, here is the lateral and here is the medial intermuscular septum, this is the deep fascia, and here is the iliotibial band. So divide the iliotibial band and the intermuscular septum right up a little above the knee, and that is called as Yount's operation, the basic operation for knee correction. In ankle you have equinus, you can do tendoculus lengthening. In the subtalar joint there is inversion. This is the tibia, this is the talus, interosseous talocalcaneal ligament and calcaneum. This is the flexor retinaculum. In between you have the porta pedis. So you divide the flexor retinaculum, the tibialis posterior, the flexor digitorum longus, save the artery and nerve, divide the flexor hallucis longus, and divide the medial half. Divide the medial half of interosseous talocalcaneal ligament. So what are the structures in the porta pedis? Remember, the doctors are not here. Tibialis posterior, flexor digitorum longus, TP, flexor digitorum longus, posterior tibial artery, posterior tibial nerve, and flexor hallucis longus. So you divide or lengthen or transfer. Tibialis posterior, FDL and FHL, save the artery and nerve. Cavus, you detach first layer of sole muscles from the medial calcaneal tuberosity. And the first layer are abductor hallucis, abductor digiti minimi, and in between you have the flexor. So you have a flexor between two abductors. Flexor digitorum brevis, abductor hallucis and abductor digiti minimi, and plantar aponeurosis. You detach these from the medial calcaneal tuberosity. So this is how you correct contractures. After correcting contractures, you either give an orthotic device in case of extensive paralysis, or you do a tendon transfer bone block or fusion operation. So this finishes poliomyelitis.